introduction and the invitation to speak. So I'm going to speak about upper GI bleeding. So we'll go through just kind of recognition of the condition, some evidence-based resuscitation and transfusion strategies, and then thinking about assessment of risk for the individual patient and therefore the urgency of endoscopy. And then I'll go through some different kind of pharmacological, endoscopic and other management options. So to start with a bit of background to it, so upper GI bleeding is a very common medical emergency. So we get about 60,000 presentations to hospital per year in the UK. We've had various audits done in 2007 and 2022 of UK practice, and it shows that the patient population is changing a little bit over time, becoming of older age, a bit more comorbid, and there's increasing use of anticoagulants. About 2/3 of presentations are new admissions to the hospital, with the rest accounting for patients that are already within the hospital setting, and they have median age 69 and a slight tendency to be male. Mortality was quite stagnant at around 10% over about 50 years or so, but actually in the last 15 years, there's been a slight improvement to 8.8%, of which only 3.7% of that is actually directly related to the bleed, and the rest is through other comorbidity or complications. Cirrhosis is increasingly common, and this is now present in about 15% of patients. Sorry, I'm trying to get rid of the bits at the bottom. A lot of the management I'll sort of speak about here is based on the UK guidelines that are published by the British Society of Gastroenterology, but with also some input from an international kind of consensus group on portal hypertension called Baveno. So in terms of clinical presentation, it's often by production of blood that you can see coming from the GI tract. So that's either hematemesis, so vomiting blood that might be fresh, bright blood, or it may be partially digested and appear like coffee grounds. The majority of patients present with melena, so that's the digested blood that appears as black, tarry, sticky stools with a fairly characteristic smell as well. But if upper GI bleeding is very profuse, there may be rapid GI transit, and so passing blood PR, which is hematochezia. Blood abnormalities may show a hemoglobin drop and a urea rise because of the high protein meal associated with it, and there may be hemodynamic instability, and particularly in the inpatients, sometimes these things are noticed before any visible GI bleeding makes itself known. In terms of etiologies, it's important to differentiate really between the likelihood of varicose versus non-varicose bleeding, because they're associated with different risks and slightly different management strategies. So varicose bleeding is portal hypertensive in nature, and the commonest cause of portal hypertension is chronic liver disease, but it can be non-cirrhotic as well. Patients would often have things like ascites that you may be able to see on examination, or spider nevi, or they may have a known history or known previous endoscopies showing varices. Varicose bleeding accounts for around 16.5% of the new admissions with GI bleeding, and it has a higher than the background GI bleeding mortality of 13.7%, and that has improved over recent years. Even if you have chronic liver disease, it doesn't mean it's going to be varicose or any kind of portal hypertensive bleeding. So it does account for 70% of bleeding in those individuals, but do think about the other causes also. And if it is varicose bleeding, it's more likely to be esophageal than it is gastric or coming from other areas. In terms of non-varicose bleeding, the commonest cause is peptic ulcer disease, or there may be some kind of itis of the esophagus, stomach, or duodenum. There can be Mallory Weiss tears, which are tears to the bottom of the esophagus caused by vomiting. There are various upper GI malignancies that can bleed, aberrant blood vessels such as Dieulafoy lesions, where an arteriole may erode through the lining of the stomach, or angiodysplasias that often give a slightly slower bleed. So in terms of initial management, resuscitation is key. So it is an ABCDE approach. Perhaps consciousness is impaired by shock or severe hepatic encephalopathy, and so consideration of airway support is important, as well as their breathing. But obviously it's mostly a circulatory problem, and so people need 2 large bore cannulae if there is suspected GI bleeding in order to be able to deliver that resuscitation, and then obviously taking off blood tests for your standard cohort, including renal function, full blood count, liver tests and clotting, and then a group and save. An ECG is important to judge their risk of cardiac ischemia or any arrhythmias. And then the general policy for fluid resuscitation is to use a crystalloid, and recommended 500 mils over 15 minutes if there is any hemodynamic instability. In terms of aims of resuscitation, you aim for a target mean arterial pressure of around 65 millimeters of mercury or above, and that translates to a systolic of around kind of 90 to 100, and heart rate less than 100, and a reasonable urine output of greater than 0.5 mils per kilogram per hour. These targets are particularly important in chronic liver disease, as we've kind of discussed already, not to over-resuscitate patients that can promote more bleeding. If there is persistent hemodynamic instability despite that initial resuscitation measures, then really we should be considering whether or not this patient needs ITU support and review, and then think about triggering the major hemorrhage protocols. So in terms of transfusion strategies that I think Stephen will probably talk more of a bit later on, but multiple studies have looked at restricted versus liberal transfusion strategies. And so meta-analyses of these have actually concluded that a restricted transfusion policy is better and associated with lower mortality. It reduces rebleeding in GI bleeds, it reduces transfusion requirements, and this all translates to actually a reduction in hospital length of stay also of up to 2 days. One of the key studies that contributed due to its large number of participants to this conclusion is one by Villanueva, which was a multi-center study in Spain. And you can see here the survival curves show that there's improved survival if you have transfusion triggered by hemoglobin less than 70, which is the restricted arm, versus a more liberal transfusion threshold of hemoglobin less than 90. And if you then look at some subgroups of patients, you can see that this is particularly profound or important for those with liver disease, Child-Pugh class A or B, where you can see that large kind of survival benefit with the more restricted policy. This is then translated into our kind of national guidelines. So if there is hemodynamic instability in patients, then the transfusion trigger is less than 70. If it's variceal bleeding, it's quite a tight target of 70 to 80 hemoglobin. If there's ischemic heart disease, because of the risk of cardiac ischemia, there's a slightly more liberal target of 80 to 100. And if there's major hemorrhage, then the HB will obviously dilate a bit too slowly to use that as a trigger. And so it's more clinically led, but always trying to maintain, if we can, a hemoglobin greater than 70. Despite there being quite good guidance of this, in the UK audit in 2022, we're still probably using transfusion inappropriately in around 24% of cases. So there's still a little bit of awareness and work to be done with that. In terms of coagulation management, around almost a third of patients are on some form of anticoagulant presenting with a GI bleed, and 22% are on antiplatelets. If safe to do so, the first step is usually just to stop those things, so stopping warfarin and DOACs. And if there is a reasonable severity of bleeding, warfarin may need to be reversed with vitamin K and perhaps prothrombin complex concentrates. DOACs have got a relatively short half-life, so in most cases, reversal agents aren't needed, but if there is quite profuse bleeding, then those reversal agents can be considered. Thinking about the P2Y12 inhibitors like clopidogrel and prasugrel, if they're indicated because the patient has had a cardiac stent within the last year, generally we would consider them unless there's really profuse major hemorrhage, because actually stopping them within that time period gives them about a 40% chance of an MI and therefore worse outcomes because of that. So if it needs to stop, we would generally discuss with cardiology about the pros and cons. Aspirin, though, is a slightly different story. So although it may prolong bleeding time and it to some extent worsens outcomes from the GI bleed itself, it does reduce cardiovascular events and overall mortality because of those cardiovascular compromises. So actually the benefit is to continue aspirin despite bleeding. We've already discussed in the transplant talk, but tranexamic acid is out and not recommended for GI bleeding, and that's been evidence in the HALT-IT study, and it can increase the risk of thromboembolic events. And then platelet transfusions really are only indicated if platelets fall to less than 50 in the presence of active bleeding. And the standard coagulation markers of INR and PT are not reflective of coagulation status in liver disease. So, as already discussed, consider other methods of investigation, such as using ROTEMs or TEGs in major or uncontrolled bleeding to consider correction in those settings. Before endoscopy, if patients are on non-steroidal anti-inflammatory drugs, they can cause peptic disease, and so we would stop those. Quite commonly, people give proton pump inhibitors such as omeprazole, but actually there are numerous studies and meta-analyses that show that they don't actually improve patient outcomes in terms of bleeding or mortality. There may be some benefit in reducing the presence of high-risk stigmata when you go in and have a look endoscopically, and therefore the need for endoscopic treatment. So there's no clear benefit to giving it, but perhaps reducing intervention that way. But it is helpful to give some kind of prokinetic if there's a reasonable GI bleeding, such as erythromycin or metoclopramide, 30 minutes before endoscopy, because it improves views at the time of endoscopy and therefore the ability to diagnose and treat. John? Oh, yeah. In addition to these measures, particular for patients with liver disease, is the benefit of giving prophylactic antibiotics. So in the UK, we recommend ceftriaxone 1 gram IV once a day that can be given for up to about 5 days. And this is known to reduce mortality, and it reduces incidence of infections by reducing bacterial gut translocation, and it also reduces portal pressure. This applies to both bleeding that is through peptic ulcer causes as well as variceal bleeding. Particular to variceal bleeding, or the suspicion of variceal bleeding, though, is the use of terlipressin, so 2 grams 4 times a day IV. And this is a splanchnic vasopressor, so this will reduce portal pressure and therefore the pressure that's causing the bleeding, because it's a pressure rather than the bleeding issue that is variceal bleeding. It reduces mortality, helps improve homeostasis and reduces transfusion requirements, but it does come with significant risks and various contraindications. So there's risks of ischemia, respiratory failure, or acute hyponatremia. It's contraindicated if there's ischemic heart disease or peripheral vascular disease or uncontrolled hypertension. And so certainly in our trust, we expect that to be a senior led initiation of the drug rather than one led by an SHO or an F1 in ED. And it's all important to think that there should be some reasonable filling of the circulation before giving terlipressin, otherwise you're squeezing an empty circulation and leading to ischemia. There are various risk scores that can be used for GI bleeding that may help identify low-risk patients that can be managed as an outpatient, or they can help the time of endoscopy or need to consider ITU or higher level care, and also predict outcomes when thinking about prognosis for patients. We recommend use of the Glasgow Blatchford score, which is particularly useful because it uses just pre-endoscopy factors and can identify low-risk patients, whereas scores like the Rockall scores use both pre- and post-endoscopy parameters, and that's a bit more predictive of overall mortality. So this is the Glasgow-Blatchford score. You can see that it comprises elements of urea, so the amount of blood protein meal, hemoglobin, full hemodynamic parameters of systolic blood pressure, heart rate, and presence of syncope. The presence of melena to say that there is reasonable bleeding and GI transit, and then comorbidities of severe liver disease and cardiac failure that then play into overall prognosis. So each of those gets different amounts of points. If you then think about the timing of endoscopy, those with a very low Glasgow-Blatchford score of 0 to 1 are very low risk of coming to harm from a bleed or needing endoscopic intervention. So actually they can be discharged and managed as an outpatient. But the vast majority of people will have something greater than that and generally require an endoscopy within 24 hours. And that can usually wait till the next endoscopy list in the morning if it's happening in the evening. But urgent endoscopy within 12 hours or even sooner than that may be indicated if there's ongoing hemodynamic instability, particularly if that's recurrent after initial resuscitation measures, if there's suspected variceal bleeding, or if we're having to trigger the major hemorrhage policy. And so that can be discussed with an on-call endoscopist at any time of day or night. Like I mentioned, adequate resuscitation is needed, and that does facilitate a safe endoscopy. And if there is severe hematemesis and that suspicion of variceal bleeding, airway support may be needed, and so perhaps the endoscopy is best done with the patient intubated, and so involving anaesthetics in ITU in that time and thinking about what's going to happen to the patient post-endoscopy is also important. So at endoscopy, like I said, peptic disease is usually the most common thing here. And you can risk stratify by what you find at endoscopy. So these are pictures of different ulcers with high-risk stigmata, the highest risk of rebleeding and death at the top and the lowest risk at the bottom. And really, we only need to treat ulcers with high-risk stigmata, such as active bleeding, visible vessels, and even if they have a blood clot, perhaps treating those and removing the clot and seeing any vessels beneath. Often we use adrenaline injections. That's a temporizing measure just to vasoconstrict and also use the tamponade effect of the injection itself. We may then use additional measures such as heater probes or bipolar coagulation or putting mechanical clips on top. If it's a slow, oozy bleed, then we can use topical therapies such as hemostatic powders or Puristat. And generally speaking, if there are high-risk stigmata, we'll use a combination of therapies which are known to have better treatment than a single therapy on its own. If it is peptic, think about H. pylori infection that predisposes to ulcers as well as cancers. And so testing for this that can be done at the time of endoscopy and then offering treatment afterwards. Or if it's something like angiodysplastic bleeding, that can be treated with argon plasma photocoagulation. For variceal bleeding, like I said, this is most likely to be esophageal varices that are bleeding. And you can see in the picture marked A, a protruding esophageal varix running down the esophagus there. This is treated with variceal band ligation, where the section of the varix is sucked up into a cap at the end of the endoscope and a rubber band put over it that then ties off that varix and stops the bleeding. Gastric varices are less common and less likely to bleed, but when they do, they bleed more profusely. And banding generally doesn't work unless they're connected across the GOJ, the gastroesophageal junction, to esophageal varices. So the mainstay of treatment for gastric varices is injection of cyanoacrylate glue, and in some centres they use thrombin injection as an alternative to that. Despite best efforts, about 12% of variceal bleeding cases can't be controlled if bleeding at time of endoscopy. And so then need to think about giving them some kind of bridge to get them to a more definitive therapy. So most commonly used in the UK is a Sengstake and Blakemore tube, which is pictured here, where you inflate a gastric balloon and then pull it under some pressure against the gastroesophageal junction. And that occludes the inflow to esophageal varices, and it may directly compress gastric varices to stop bleeding that way. But it's associated with high risks of complications, requires the patient to remain intubated and therefore in ITU. There are also self-expanding metal esophageal stents that just get placed within the esophagus and are good for variceal bleeding and don't require ongoing intubation. But there's a little bit less familiarity, I guess, with this in the UK and perhaps a bit less availability. For most patients, post-endoscopy care, if it was a peptic cause for their bleeding and they had high risk stigmata requiring endoscopic therapy, they would be treated with 72 hours of intravenous PPI, such as omeprazole 80 milligrams 3 times per day. Or if they're a lower risk, they can be using oral lower dose equivalents. If it was a variceal bleed and there was no peptic cause, it's important to stop a PPI if they were started it on admission, because actually that's associated with greater harm. If hemostatic control is gained, they can probably then stop their ceftriaxone and terlipressin. Usually you would often wait about 24 hours to be sure that there is good hemostasis achieved. Or if you are continuing it, you usually stop it after about 5 days. When stopping terlipressin, it's important to instigate secondary prophylaxis for bleeding. And so this is by a non-selective beta blocker, so usually carvedilol, to reduce portal pressures in the initial setting, and then they would go on to a later banding program. Because of the large blood meal associated with variceal bleeding and in the presence of liver disease, that can trigger hepatic encephalopathy by increasing the amounts of ammonia in the bloodstream that can then affect brain function. And so this is counteracted by giving lactulose that helps to empty the gut and reduce ammonia production as well. So that's recommended prophylactically in the case of liver disease. And then thinking about why did they have a variceal bleed in the first instance. And so we would generally do a liver triple phase CT looking to exclude any new onset portal vein thrombosis and exclude any primary liver cancers, which each would then have their own particular treatments. In all patients, it's important to monitor for signs of rebleeding, and ultimately the median length of stay for people in the UK is around 5 days. If there is bleeding, it does occur in about 8% of patients, and it's usually a bit sooner rather than later, so median of 2 days. It does have a higher mortality than general first-time presentations, and about half of that, or just over half of that, is directly bleed related. For most patients, the line of management would be a repeat endoscopy unless something was identified at the initial endoscopy to say that it would not be amenable to endoscopic therapy. Other treatments are, or other investigations are with CT angiography, and that's usually with a view to identifying a bleeding source and then being able to guide interventional radiology to do arterial embolization of bleeding vessels, often in ulcers. And this is increasingly common and a really good treatment for patients. If bleeding is portal hypertensive and variceal in nature, then the treatment is often with a TIPS or a transjugular intrahepatic portosystemic shunt, and I'll speak about that a little bit more in a minute. And they can have some embolization of bleeding varices or shunts at the time. Increasingly used less is surgery. So that's mostly been overtaken by interventional radiology, but occasionally there may be patients that require a surgical intervention, such as oversewing of an ulcer, in order to control their bleeding. So a little bit more about TIPS. So this is basically creating a shunt or a false connection by a stent transversing from the portal vein to a branch of the hepatic vein that immediately offsets portal hypertension and lowers portal pressure, and therefore the driver of variceal bleeding. So it's indicating if there is uncontrolled variceal bleeding. So this is what you're working up to if you've put in a Sengstaken and Blakemore tube or a temporary esophageal stent. It can also be used if there is secondary need for prevention of recurrent variceal bleeding, and particularly in the case of gastric or other ectopic variceal bleeding. And there's increasing evidence to use it actually preemptively. So if you have a variceal bleed with active bleeding that is controlled endoscopically at index endoscopy, and the patient has liver disease Child-Pugh B7 to C13, there's evidence to do a TIPS within 72 hours that improves overall bleeding and mortality outcomes. There's a bit of controversy to this, so lots of good data in European studies, but actually one of the UK studies did not show a benefit, and there's a current large multi-centre study looking at this again within the UK. The risks of TIPS, though, are that because blood is now bypassing the liver to a reasonable extent, you can trigger hepatic encephalopathy, so a degree of liver failure. And there's a big increase in cardiac return, and so it may put people into right heart failure. It's only available in some centres because of the limited expertise, and so you might need to think about transferring patients and then the safety of doing that if they are acutely unwell. So in terms of when a bleed has been dealt with and we're thinking about discharge, if they are low risk on Glasgow Bachelor score, they could probably go straight away. Or if they are treated and things have settled, if things are stable after about 24 hours, they can go then. If there have been changes to anticoagulants or antiplatelet agents, that needs some kind of review and plan made. And that all depends on the individual, the indication for it, and what was found in terms of bleeding risk and risk of recurrence. If anemia has been caused by the bleed, there is good evidence to support use of iron supplementation, which speeds recovery of the hemoglobin and the symptoms associated with that anemia. And IV does tend to work a little bit better than oral. If it's a peptic cause, patients would generally go home on an oral PPI like omeprazole or lansoprazole for at least 1 to 2 months. And if it was an ulcer causing it, they would generally have a repeat endoscopy at 6 weeks to make sure that that ulcer isn't a malignant one, so an underlying malignant cause of that would require treatment. If it was a variceal bleed, they should be going home on a non-selective beta blocker such as carvedilol if there are no contraindications, and they would have planned repeat endoscopies on a variceal banding program every 2 to 4 weeks for further banding until those varices are eradicated if they haven't been treated with TIPS already. So in summary, it's important that there's early recognition of upper GI bleeding and ABCDE assessments with good resuscitation to improve outcomes. Restrictive transfusion strategies of HBs less than 70 as a trigger does improve outcomes. Antibiotics and terlipressin should be considered in variceal bleeding and are associated with improved outcomes. Risk stratification with Glasgow Bachelor scores helps to prioritise endoscopy, but in the majority, endoscopy is needed within 24 hours or earlier if they're unstable or have suspected variceal bleeding. Combination therapy is needed for high-risk ulcers plus 72 hours of intravenous PPI. But for variceal bleeding, banding is generally the treatment of choice, and then non-selective beta blockers and further banding prophylaxis or consideration of TIPS. So these are some key references, and I'll welcome any questions.
Brilliant, Christina. Thank you very much. That was excellent. I feel like we've covered a really great range of topics this morning. There's actually loads of questions in the Q&A and in the chat. I am conscious that in the interest of time, we should probably move on to Stephen's talk. But would you mind having a look at the questions that are in the chat and in the Q&A? Because I'd quite like to hear all the answers to them as well. But that was excellent. Thank you very, very much. Oh, and I'm just adding a comment just on the end because you mentioned Andexnet when you referred to anticoagulation, which has become one of my recent hobby horses, is to get people to use this drug less. If people haven't seen it, there's the BSH position statement that I've just put a link to in the chat on the use of Andexnet. But thank you very much, Christina. And I think hopefully we have Stephen with us.
Hello, can you hear me?
I can hear you absolutely fine. Yes.
Perfect.
Thank you very much for joining us, Stephen.
No problem. I won't put my camera on today because my signal's a bit, well, my network's a bit dodgy, so I don't want to lose everything if I put my camera on. If that's okay.
Yeah, of course it is.
Yeah.
That's no problem at all. So Stephen White is the Transfusion Laboratory Manager at University Hospitals Bristol, and is going to talk to us about major hemorrhage from a lab perspective. Stephen, do you want to share your slides, or would you like Samir to share them?
I've got them here. I can share them. That's fine.
Perfect.
Yeah. Hopefully you can all see that.
Yeah.
Yeah,
perfect. Thank you very much.
So yeah, as Sarah said, so I'm Steve White. I'm the Transfusion Lab Manager for University Hospitals Bristol and Western. When I was first asked to do lab perspective on major hemorrhage, I thought, great, lots to talk about. It's going to be a nice, easy talk today. However, it's actually really simple from the lab point of view. We just dish out blood essentially. So again, to try and link this into GI bleeding, I thought I'd look at the most recent NCA audit covering major hemorrhage. And as you can see here, GI bleeding nationally is the second largest reason for major hemorrhage calls in the UK. Only behind obstetrics, and then trauma was the third. So at UHBW, we are not a trauma centre, and we actually see a very similar pattern to this in our own hospital, with obstetric bleeding being our highest cause of major hemorrhage, closely followed by GI bleeding. We don't have the trauma. Obviously, interesting with this is most major hemorrhage protocols are written and follow a process of trauma, with shock packs following that trauma protocol, generally of a 1-to-1 FFP to red cells. Although they said trauma is only the third highest. And yeah, with GI bleeding as well, second highest cause of major hemorrhages, but it's got the highest transfusion rate, with 95% of people with a GI bleed being transfused from their shock pack. And again, you can see compared to your obstetrics, it's only 68% transfused, and trauma is only 90% transfused and calling a major hemorrhage. So yeah, moving on. So again, from a lab point of view, it's really, really simple. We get that bleed and hemorrhage is activated, and we essentially just start pumping out our shock packs. Every hospital should have their defined shock pack process. And for us, it's 4 red cells in the first pack, then 4 red cells, 4 FFP. Yeah, essentially, again, really, really simple. So, sorry. BSH mandate here is that close lab clinical work is not optional, and it is required for timely targeted transfusion in support of major hemorrhages. And again, it's not a single test result. So once a major hemorrhage activation is gone, it triggers that coordinated response. So it's important that you keep that close communication with the lab. It's not just that I've activated that, I'm just going to get what they want or what I want. There is that communication that's needed. You do need to communicate with the lab and let us know what's going on in the clinical area. And again, we can then talk back and say how we're getting on with test results, if blood is available to be cross-matched, or if it's still going to be the emergency group O. And that the lab does need to be involved in this as much as possible. And again, we can also help coordinate some things. So again, if there's coordination needed with a hematologist or heme SPR or consultant, again, we can do some of that communication as well. If there's questions on what components or different products that might be needed, you can get that help through the lab as well. You can say to the lab, you don't know what you're after at that point, and we can then contact the hematologist and get some help and advice. Right, just not moving on. So yeah, as I said, like essentially the major hemorrhage is called, and it just eases blood release. It removes, I put removing all barriers. I think the way we look at it is that with a normal blood release, we obviously have all that paperwork, cross-matching, compatibility up front, and then the blood's released as the last product. Essentially, with the major hemorrhage, from a lab point of view, we just switch that. We get the blood out first, and then we worry about compatibility, what testing we need to do, and any follow-ups after. And again, it's standardized. each hospital will have their set process and what blood to release at that point. And again, just ensuring that readily available group O red cells and universal plasma, so either AB or A high T to neg, depending on what your hospital uses. And again, different hospitals will have different things. So that's essentially that. So some balanced transfusion, so some logic behind the ratios, why different hospitals will use different things. So I said at UHBW, we are not a trauma center. Traumatic hemorrhage evidence points towards a 1-to-1 ratio of red blood cells and FFP. So that's probably what you would get in your first pack if you are a trauma center. We are not, so we more go ongoing. We follow sort of an ongoing major bleeding process, where in that first shock pack, you will only get 4 red cells, and then you get the FFP following that. And then it follows a 1-to-2 ratio. And then that's not till shock pack 3 you'd standardly get your platelets. Again, that's not to say if you need anything sooner in that hemorrhage. It's about being aware of what your hospital's process is and communicating with the lab and saying, I need shock pack B straight away, or I need shock pack C now, rather than waiting for that A, B, C process, because it may be that you need all those products up front. Most trusts will have pre-thawed FFP, not all trusts. So again, it's just to be aware on what's available in your trust, so that if you did want that FFP up front or you did want that earlier, it may take some time to thaw. And again, depending on the trust, that could be anywhere between 20 minutes to 30 minutes to thaw that FFP for you. So again, it's just making sure you communicate clearly with the lab on what you require. Just a bit more, and again, this is more of a question and a point, especially with GI bleeding. Is FFP required in the first shock pack? Not necessary, and this is what some of the evidence suggests. I'm obviously not a clinician. I'm not going to tell you what you should or shouldn't be given, but local policies will change in trust depending on what those specialities they see and what is expected of bleeding. Again, we're quite lucky in our trust. A lot of the hemorrhages, we don't usually get past shock pack A before the bleeding is controlled, and then they don't need or want that FFP, so we rarely get to a point of handing that out. But it's important to understand what you will be getting. Fibrinogen concentrate. So fibrinogen, sorry, it's not a given. Cryoprecipitate isn't automatic in, I don't think, any shock pack system or any major hemorrhage protocol I've seen on any trust. So again, it's that looking to see when you would or if you will need fibrinogen, and then asking for that separately. And again, depending on what your trust has, that we do have the cryoprecipitate, which we can thaw, which takes 20 minutes, or we do have a fibrinogen concentrate, which is available immediately. So again, it's looking to see what you will need, when you will need, and communicating that clearly to the lab, and just understanding what isn't in those shock packs. Don't just assume you will be getting your cryo as part of that process. And I guess, I mean, this is the main point, and the lab just provides the products. It's the clinical team's decision on what to give. So the lab's role is to perform those tests, to release those products quickly, and to follow up with any compatibility, any potential mismatches, and make those alerts. It's the clinical team's job, your guys' roles, to obviously evaluate the patient and decide what's being needed. I guess the take-home message there is, just because we've given you FFP or because we've given you platelets, if you don't need it, you don't have to give it. You still need to make those decisions, whether it's a major hemorrhage or not, on what your patient actually requires at that time. So yeah, it's just because we might have sent FFP out in the first shock pack, doesn't mean you have to give that immediately if it's not required. And then I guess all the follow-up. So see, we issue these products out quickly. They may not be compatible, they may not be matched. We may find out the patient's got antibodies following. So it's important for us to be able to follow that up and involve hematology SPRs or consultants as and when is required. So it may be that we've sent some blood out and then we found out the patient's got an antibody. We will obviously contact the clinical area and tell them there's an antibody, be aware your patient may have a transfusion reaction. We would also consult with the hematology SPR and say, again, there has been there's a hemorrhage called in next area, and we've discovered the patient has antibodies, and the blood we have given has been positive for those. So you will just need to be aware you might need to manage a transfusion reaction. So again, we make that contact and let everyone know on that point. Equally, it may be that we get a feel that someone might not know necessarily what they're asking for. So they may be asking for a ridiculous amount of PCC or fibrinogen concentrate. It may be needed, it may not. It's not our decision to give that clinical advice or to help with any of that. We will just, again, refer those on. We wouldn't necessarily withhold any products. We would make sure products go out immediately so that they can be and are available for use. But we may need to just contact the heme team and just say, I think some help might be needed in this area. And again, I said at the top, at no point can any biomedical scientist offer any clinical advice. I think that's clear. That needs to be made clear sometimes, because we do get phone calls asking on how much or what volume ratio of products should be given, or what dose of PCC should be given for this patient. And again, we can't make that decision. We're not allowed to give that advice. So again, we will report that onto hematology and get that advice to you if it's needed, but just that won't be immediate. And again, it's important, I think, with any big case as well, from a transfusion point of view, is to make sure the labs were involved in any review and follow-up or any audit. Quite often, there'd be a major hemorrhage review or a patient review following, and transfusions sort of left out of those conversations. I think it is good to get some of that involvement from transfusion in those, so that we can help shape and guide any guidelines or changes in process policy going forward. And again, I think this is another good point from a transfusion perspective on major hemorrhages. Quite often we do simulations in isolation, so clinical teams might do a simulation for major hemorrhage. And again, equally, we do it in the labs where we go through processes and procedures with our scientists on how to release products quickly. It's not very often we join up between the clinical side and the lab side, to do these bigger simulations, or to help improve that communication between the lab and the clinical team in these major hemorrhage situations. So it's something I'm trying to get more in my hospital, but it's, again, not always easy with time and staff availability. But again, it can help to reveal some of those gaps in where there might be communication breakdown, or gaps in policy, or just gaps on how the clinical team and lab team work and expect from each other in these hemorrhage situations. So I think it's good to get some more of these going. And that is it. I mean, I've flown through that quickly because I was just aware of time, so I just wanted to make sure we finished on time.